Hello everyone, welcome to POC Nurse. Today we're discussing acute coronary syndrome for the Ccrn exam. So there are three important things to know while studying this chapter. The three things are the types of ACS, the clinical picture associated with the different types of ACS, and the last thing is the heart walls and the leads that point to them. So when we talk about types of ACS, we're talking about, is it an anterior MI, a lateral MI, an inferior MI, or an RV infarct? When we talk about clinical picture associated with the types of MI, we're talking about, okay, if you have a patient that has an RV infarct, you'd expect them to show signs and symptoms of right-sided heart failure. And when we talk about the heart walls and the leads that point to them, we're talking about when you do an EKG and you see changes in leads V1, V2, V3, and V4, you automatically know that those four leads point to the anterior portion of the left ventricle. So you might get a question that describes the leads and the changes in them. So you should then know that, okay, if it's talking about leads V1 through V4, that this patient is having an anterior MI, which affects the LAD, the left anterior descending coronary artery, and therefore affects the left side of the heart. Now we're going to jump right into it. We're going to discuss ACS. So what is ACS? ACS is acute coronary syndrome, like we said before. And in ACS, there's acute reduction or total termination of blood flow to the heart. So ACS involves the blood vessels, and it could cause a myocardial infarction or death of the cardiac cells. So when there's a reduction of blood flow to any part of the body, there's ischemia. So in this case, when there's reduction of blood flow to the heart could become ischemic. And this is what leads to symptoms of ACS. And sometimes there might be no symptoms depending on how severe the ischemia is. Moving on, we're going to talk about risk factors for ACS. So the risk factors are twofold. They could be modifiable and non-modifiable. When we talk about the non-modifiable risk factors for ACS, we're talking about things like a person's age, a person's sex or gender, a person's genetics, and their family history. In terms of modifiable risk factors, we're talking about things like smoking, diet, drinking alcohol, hypertension, diabetes, hyperlipidemia, obesity, and a person's level of physical activity or lack thereof. Like we spoke about before, in ischemic heart disease, there's reduction of blood flow to the heart. And ischemic heart disease can be a symptomatic coronary artery disease, or it could be symptomatic in the sense where a patient has stable angina and the patient has chest pain when the patient exerts themselves, but once they rest, the pain goes away. So in this case, we're talking about chronic ischemic heart disease, where the patient has had this for a long time and they get symptoms or no symptoms depending on the kind of ischemic heart disease that they have. Moving on to acute coronary syndrome, it's a type of ischemic heart disease, but this happens acutely, it's not chronic. So in ACS, in acute coronary syndrome, there's sudden reduction or termination of blood flow to the heart. And it can be caused usually by a narrowing of the blood vessels due to thrombosis from platelets. In this case, there is a thrombus in the vessel that's making the lumen of the vessel smaller and therefore reducing blood flow to the heart. ACS can also be caused by coronary spasms, where the vessel itself, contracts and gets smaller. Now, ACS can cause sudden cardiac death, so the patient can go into cardiac arrest from this, depending on how severe the reduction of blood flow to the heart is, or it could be total termination of blood flow over time, and the patient's heart stops. So when patients present with symptoms of ACS, which is usually chest pain, they get an EKG within 10 minutes, they get blood work and a couple of other things that I'll talk about down the road. One thing to keep in mind that even though the most popular symptom of ACS is chest pain, there's a group of people who will have ACS but will not complain of chest pain, and these people are your diabetics and women. They typically may not complain of chest pain. They may have other symptoms, but not chest pain. Maybe not chest pain. So there are three main types of ACS. There are actually four, but three main types. The three main types are unstable angina, NSTEMI, which is non-ST elevation myocardial infarction, and STEMI, which is ST elevation myocardial infarction. In unstable angina, the patient will complain of chest pain at rest. The patient may get relief from this chest pain when given nitroglycerin. Troponin on lab work will be negative. On EKG, the patient may show ST depression or T-wave inversion. Moving on to the NSTEMI. In NSTEMI, the patient will have unrelenting chest pain, meaning the patient may not get relief from any medication. Troponin will be positive in this case, and the patient will have ST depression or T-wave inversion on EKG. In the case of a STEMI is a medical emergency. In the case of a STEMI, the patient will also have unrelenting chest pain with no relief likely from nitroglycerin or pain medication. Troponin will be positive, and there will be ST segment elevation in 2 or more leads. The fourth type of ACS is called variant or Prinzmetal's angina. It's usually due to spasms in the coronary artery. It could happen when a patient ingests alcohol, nicotine, or cocaine. It causes a transient ST segment elevation that goes away once the vessel obviously returns to its usual form. That is, the spasm goes away. And this type of ACS can be treated with nitroglycerin, where the patient takes nitroglycerin, the vessel relaxes, and the ST elevations on EKG will resolve themselves. The patient's EKG will return back to their baseline. So that's what happens with the variant of Prinzmetal's angina. Next, we're going to talk about treatment/assessment for acute coronary syndrome. So, meaning what happens when a patient complains of acute chest pain. So, the first thing we do is get a stat EKG within 10 minutes. This will help us differentiate. First of all, it will tell us if this chest pain is cardiac in origin or something else. It could be gastric issues the patient is having. So, it'll rule out cardiac or any other issues. Secondly, if it's cardiac, it'll tell us if the patient is having a STEMI, NSTEMI, or unstable angina. So if the patient is having a STEMI, there'll be ST segment elevation. If the patient is having an NSTEMI or unstable angina, there will be ST depression or T-wave inversion. The second thing we do, and this is in no particular order, second thing, the patient gets chewable aspirin. Next thing, the patient is going to get an anticoagulant such as heparin or Lovenox. Patient also gets an antiplatelet, which could be Plavix, also called clopidogrel, Riopro, also called abciximab, integralin, also called eptifibatide, or agrestat, also called tirofiban. So I took time to say these out loud to myself because I want to memorize these and remember them. I notice when I do questions, the generic names of medications come up, and I usually will memorize the manufacturer's name for the medicines because they tend to be easier to remember. So just a tip, it's important to memorize both names so that when you come across them in a question, you automatically know, okay, this is a question about acute coronary syndrome, this is an antiplatelet, and then you can kind of move on from there. All right, so remember, antiplatelets are Plavix or clopidogrel, Riopro or abciximab, integralin or eptifibatide, and agrestat, also known as tirofiban. Beta blockers are also given, but the beta blockers have to be cardioselective. Lopressor, also known as metoprolol, is a cardioselective beta blocker. Now, propranolol, also called Ingerol, is a non-cardioselective beta blocker. It is not given in ACS, but I've seen it as options in questions I've been doing in ACS cases. So propranolol or Ingerol are non-cardioselective, not to be given in ACS. Instead, we give Lopressor, also called metoprolol. Other contraindications for beta blockers in ACS is if the patient's chest pain is due to cocaine use, we don't give beta blockers. If the patient is hypotensive already or bradycardic already, we don't give beta blockers because it will only make the situation worse. Beta blockers will reduce a patient's blood pressure and reduce the heart rate. Now, if the patient has taken a phosphodiesterase inhibitor like Viagra, also known as sildenafil, they don't get a beta blocker because the Viagra itself will lower the patient's blood pressure, and if you give a beta blocker on top of that, the patient could get even more hypotensive. Another thing, the last but not the least thing, not necessarily the last, but something else that we do in ACS is an assessment. The assessment kind of goes through the entire process. You start assessing from the minute the patient walks in to the minute you hand the patient off to somebody else. So in assessment, we send labs for the patient to check cardiac biomarkers, check their lipid profile, check electrolytes. You send a CBC as well. You want to see what their hemoglobin looks like. You want to see what their white count looks like, and all that good stuff. You take a history from the patient. You need to find out, do any family members have a cardiac history? Has anyone ever had a cardiac event in the family? And things of that nature. You also do a physical assessment. You listen to the heart. Does the patient have any murmurs? You look at the patient. Is the patient diaphoretic? Is the patient clutching at their chest? Things of that nature. So in summary, how do we treat a patient with ACS? EKG, chewable aspirin, anticoagulants, antiplatelets, a beta blocker, and assess the patient. We're now going to talk about EKG changes, leads on EKG, the coronary vessels that these leads point to, and the heart walls that they point to. So I want to start by telling you about a mnemonic that I use to help me remember the EKG leads and the walls that they point to. So it's called SALI, SALI. So the SALI stands for septum, the A stands for anterior, the L stands for lateral, and the I stands for inferior. So the S, septal, points to leads V1 and V2, or leads V1 and V2 point to the septal portion of the heart with this mnemonic only. Then leads V3 and V4 point to the A, the anterior portion of the heart, and the L, we have leads V5, V6, 1 and AVL point to the lateral portion of the heart. And when we come to the letter I, the leads 2, 3, and AVF point to the inferior portion of the heart. So I use this mnemonic to remember this information and to answer questions about EKG changes and the portion of the heart that they point to. Now, I'm going to talk about the EKG changes, their corresponding leads, coronary vessels, and heart walls that they point to that I studied up in my book. So, EKG changes in leads V1 and V2 point to the right coronary artery and the posterior left ventricle. EKG changes in leads V1, V2, V3, and V4 point to the LAD, the left anterior descending coronary artery, and the anterior portion of the left ventricle. Changes in leads V3R and V4R point to the right coronary artery and point to a right ventricular infarct. So when we do a right-sided EKG, we take leads V3 through V6 and we put it on the right side of the chest. So changes in leads V3R, not V3, V3R meaning V3 on the right side, and V4R meaning V4 on the right side, are pointing to the right coronary artery and signify a right ventricular infarct if there are EKG changes. Moving on, changes in leads V5, V6, 1, and AVL point to the circumflex artery and the lateral side of the left ventricular wall. Changes in V5 and V6 still point to the circumflex, still point to the lateral wall of the left ventricle, but the lower portion of the lateral wall of the left ventricle. Changes in 1 and AVL point to the high lateral wall of the left ventricle and still pointing to the circumflex. Changes in leads 2, 3, and AVF point to the RCA, the right coronary artery, and the inferior portion of the left ventricle. So these are the EKG changes that we can see, and the portion of the heart wall they point to, as well as the vessels that are affected. So you can see using the SALI mnemonic is a little easier to remember this information, but different things work for different people. So whatever works for you is fine. If this works for you, and it's good. Okay, I'm gonna move on to the 4 types of acute MI. So the 4 types of acute MI are inferior MI, meaning inferior myocardial infarction. Second is right ventricular infarct, anterior myocardial infarction, and lateral myocardial infarction. Let's start with the inferior MI. So in an inferior MI, we're going to see ST elevations in leads 2, 3, and AVF. It's usually caused by an occlusion in the right coronary artery, and there will be reciprocal EKG changes in the lateral wall, meaning when you look at your EKG, there will be changes in leads 1 and AVL. Now, when a patient has an inferior MI, the patient may have AV conduction issues, such as the patient may have a second degree type 1 AV block, the patient may have sinus bradycardia, the patient may have third degree AV block, and the patient may have sick sinus syndrome. One thing to take note of here is that in an anterior MI, I'm talking about an anterior MI now, the patient may have a second degree type 2 AV block, and this is an ominous sign in an anterior MI. So moving on with the inferior MI, I just wanted to kind of draw a distinction between the AV disturbances in an inferior MI and an anterior MI. And also you may get a question saying a patient has an anterior MI, which one of these could be a possible arrhythmia the patient might have, and they might give you all of the ones that can occur in an inferior MI and just this one second degree type 2 AV block. So if it's something you know already, you can just put that question in the bag. Moving on, the patient with an inferior MI may develop a systolic murmur due to mitral valve regurgitation, and this can happen if there's a papillary muscle rupture. So if the papillary muscles rupture, the mitral valve will kind of be open and the patient will have regurgitation, which when you listen to the patient's heart, you will hear as a murmur. In an inferior MI, patient may also have tachycardia, which could lead to a higher mortality in the patient. And an inferior MI is also associated with a right ventricular infarct and a posterior MI. In inferior MIs, we want to use, I think generally in ACS, we want to use beta blockers and nitroglycerin with caution due to the fact that they may increase hypotension, bradycardia, and reduce preload. Now we're going to talk about right ventricular infarct. So So as the name implies, the a right ventricular infarct affects the right ventricle of the heart. Um, so the right coronary artery supplies the inferior wall of the left ventricles. It also supplies the right ventricle with blood. So in a case where we have an inferior wall MI, the patient may also have a right ventricular infarct because we're talking about the occlusion in the vessel that supplies both the right ventricle and the inferior portion of the left ventricle. So if you have a patient with an inferior MI, there's a possibility that they also have a right ventricular infarct. So to find out if a patient has a right ventricular infarct, we need to do a right-sided EKG like we spoke about. So there will be EKG changes in leads V3R, V3 on the right side, and lead V4R, V4 on the right side. So in those two leads, we will have ST segment elevation. Treatment for right-sided for a right ventricular infarct is fluids. So we give fluids because we want to increase forward flow of blood in the body. We want to make sure the left ventricle has volume to push out to the body. So we give fluids. We also give positive inotropic agents because the right side of the heart obviously is infarcted, it's weak. We need to give something to help it contract better and push blood to the lungs and to the left side of the heart and then out to the body. So in a right ventricular infarct, you want to give fluids and you want to give a positive inotropic agent. And as we spoke about before, we want to avoid things that will reduce preload, meaning reduce volume in the heart. So things like nitrates and diuretics are to be avoided if the patient has right ventricular infarct. And as always, we use beta blockers with caution because if the patient is hypotensive already, you may not want to give a beta blocker because it will make the patient even more hypotensive. The third type of acute MI we're going to talk about is the anterior MI. So like we talked about before, if the patient has an anterior MI, there will be ST elevation or EKG changes in leads V1, V2, V3, and V4. And an anterior MI is usually associated with occlusion in the left anterior descending coronary artery, the LAD. There will be reciprocal changes or ST depression in leads 2, 3, and AVF, the leads pointing to the inferior wall of the heart. Like we said before, an ominous sign that's associated with an anterior MI is the second degree type 2 AV block. The patient may also develop a right bundle branch block. Now, another complication associated with an anterior MI is a possible ventricular septal defect, meaning there's a rupture in the septum between the left ventricle and the right ventricle. An anterior MI has a higher mortality rate than an inferior MI. It could lead to heart failure. The last type of MI we're going to talk about is the lateral myocardial infarction. Like we said before, the lateral leads are leads V5, V6, 1, and AVL. And an occlusion in any of these an occlusion in the left circumflex artery will usually cause SC elevation in any of these leads. So a STEMI is a medical emergency, like we said before. So when a patient comes in and we determine that the patient has a STEMI, we need to do two things. First, we need to find out when the symptoms started. If it's been less than 12 hours, the patient qualifies for reperfusion therapy, which means the patient could go to the cath lab for PCI, percutaneous coronary intervention. This has to happen within 90 minutes of the patient getting to the ED. Some hospitals don't have the team in-house, so within 90 minutes, everyone has to get to the hospital to do the procedure in the cath lab. So the interventional cardiologist has to be there, the nurse has to be there. If techs are needed, anyone that's needed has to be there within 90 minutes. The patient should be on the table. The procedure should have started. A second treatment is fibrinolytic drug therapy. And this has to happen within 30 minutes of the patient getting to the hospital, to the ED. Now, to find out if the patient is eligible for either of these, we need to see, does the patient actually have a STEMI? Is there ST elevation in 2 or more leads? Or is there new onset of a left bundle branch block? Has the patient been having chest pain? Has the chest pain been going on for less than 12 hours? We need to determine that. Has the chest pain lasted for 30 minutes? Is the chest pain unresponsive to nitroglycerin? So is this chest pain unrelenting? These are things that we need to determine to see if the patient actually qualifies for treatment. But generally, in my experience, once it's determined that the patient has a STEMI, once that is called, the patient is straight to cath lab within the 90-minute window to get treatment. So once the patient is done in the cath lab, they bring them to the CCU usually. And once you get the patient, you have to do certain things for the patient or keep an eye out for certain things. So we have to monitor the patient for signs of reocclusion. So if the patient starts to complain of chest pain again, it might be that that vessel that they opened has reoccluded again. In this case, you do an EKG or you look at the cardiac monitor. If you see ST elevations, you have to call the physician. And usually they have questions on this in the Ccrn exam and on the questions that I do usually. You also monitor for vasovagal reaction when the sheath is being removed. So the treatment for the vasovagal reaction, because it's usually a drop in blood pressure and heart rate, you give fluids to address the blood pressure and atropine to address the heart rate. So to address bradycardia, you give atropine. Now, usually a vasovagal reaction will have most likely hypotension, bradycardia, patient might be pale, nauseous, might be yawning, and might be diaphoretic. Second thing we want to do is monitor the sheath site for bleeding. So if you see any bleeding, you immediately apply manual pressure, 2 finger breadths above the puncture site, because that's where the bleeding will be coming from, because the needle kind of goes in at an angle, not straight down 90 degrees, more like an angled approach. So the puncture on the skin is not where the bleeding is coming from. It's 2 finger breadths above the puncture site. So that's where you put your finger and press down for about 20 to 30 minutes until the bleeding stops. Another thing to do is to monitor the patient for back pain, because if the patient complains of back pain, most likely the patient is having a retroperitoneal bleed, especially if it's associated with hypotension. So as usual, to address the hypotension in this case, we give fluids. And to address the bleeding, because the patient is losing blood, the patient might get blood products. Another thing we usually do in the CCU when the patient comes back from cath lab is to check the patient's pulses. So usually they will access the heart vessels through one or both groins. So whichever groin is accessed, you have to keep an eye on the pulses in that extremity. So if the right groin was accessed, you have to monitor that right groin for bleeding. You also have to monitor the pulses in the right lower extremity. So in the right leg, you have to monitor the pulses there. So these are the things, these are the patient care activities we do when the patient comes back from cath lab. You monitor for reocclusion, you monitor for vasovagal reaction when the sheath is being taken out, you monitor for bleeding at the sheath site, you also monitor for retroperitoneal bleed. So you monitor the patient for any back pain and you monitor the patient's pulses. You want to make sure that that limb is continuously being perfused and that there's no issue with perfusion. We're going to move on to absolute contraindications in fibrinolytic therapy. So like we said before, 2 treatments for STEMI. Patient can go to cath lab or patient can get fibrinolytic therapy, but not all patients can get fibrinolytic therapy, even though they do have a STEMI and they need it. So if the patient has had any previous intracranial hemorrhage, any previous brain bleed, they cannot get fibrinolytic therapy. If the patient has any kind of known structural cerebral vascular lesion, such as AVM, arteriovenous malformation, the patient can't get fibrinolytic therapy. Patient also can't get any fibrinolytic therapy for a STEMI if the patient has any kind of malignant intracranial neoplasm, so some kind of brain cancer. Fibrinolytic therapy is also contraindicated in a patient that has had an ischemic stroke within 3 months, unless that acute ischemic stroke has happened within 3 hours. In that case, the patient can get fibrinolytic therapy if the ischemic stroke has happened within 3 hours. Patient with suspected aortic dissection cannot have fibrinolytic therapy. A patient who's actively bleeding cannot have fibrinolytic therapy, unless, of course, they're bleeding from their period. If a patient is bleeding from their period, they can have fibrinolytic therapy. If the patient has had closed head trauma of a significant nature or facial trauma of a significant nature within 3
So
months,
if
the patient qualifies for fibrinolytic therapy,
they will get it or should get
so
it
these are
within
the
30 minutes of
conditions in which
arriving to the
a patient
emergency
can't
department.
get fibrinolytic
Now,
therapy
during
to
fibrinolytic
address
therapy, we need to assess
a
the patient
STEMI.
for major and minor bleeding. Major bleeding will be bleeding in the brain. How do we assess for bleeding in the brain? If the patient's level of consciousness changes, it might be an indicator that they're bleeding in the brain. So we have to assess the patient's level of consciousness. We also need to institute bleeding precautions, such as having the patient brush their teeth with a soft brush, such as having the patient use an electric razor if they need to shave to minimize lacerations. Another thing we could do is limit needle sticks. If we don't have to stick the patient for blood, we shouldn't have to. If we absolutely have to get blood from the patient, we could use the smallest bore needle available. And after getting the blood from the patient, apply pressure, manual pressure, until hemostasis is achieved. During this therapy, we also need to assess the patient for reperfusion. We also need to know that the therapy is working. So we need to assess the patient's chest pain. Is it going away? Is it resolving? Is it getting better? We also need to look at EKGs. So serial EKGs will continue. The patient will also be on the cardiac monitor. So we could look at the EKGs to see if the ST deviation or if the ST elevation has resolved itself. Another thing we have to look out for in the patient is to see if after reperfusion is successful and the chest pain resolves itself, the SC segment deviations go away. We need to see if they come back. We need to see if the patient starts complaining of pain again. We need to do an EKG then to see if the ST elevations are back again. So we need to not only assess for reperfusion, we also need to assess for reocclusion. Two other signs of reperfusion that you might get on the Ccrn exam are the fact that when the patient is reperfused, the troponin and CKMB levels could suddenly go up. That's a sign that the vessel has reopened and the area of the heart that previously was not getting any blood is now getting blood. So that sudden increase in the cardiac biomarkers is also an indicator that the patient is being reperfused. Another thing is that the patient could have reperfusion arrhythmias such as VTAC, VFib, and accelerated idioventricular rhythms. This is also due to the same mechanism of the elevation in troponin and CKMB. It's because that the area of the heart that lacked oxygen prior is now being perfused. So because of this, the patient could have some arrhythmias. Now let's talk about some complications of an acute MI. The two that I would like, for you to keep in mind, and which I do keep in mind for the most part, are that the patient could have papillary muscle rupture that can lead to a murmur due to mitral valve regurgitation. The patient could also have a ventricular septal defect. This is a rupture of the wall between the right and left ventricle. This can also cause a systolic murmur. Other complications of an acute MI are VTAC, VFib. The patient may go into AFib as well. The patient may have bradycardia, sick sinus syndrome, heart blocks, heart failure, reinfarction, cardiogenic shock. The patient may have pericarditis, a ventricular aneurysm, cardiac wall rupture, and as we said before, ventricular septal defect or papillary muscle rupture. This brings us to the end of acute coronary syndrome for the CCRN exam. I hope you found this useful or helpful. If you did, please like and subscribe and share this video with your friends. Thank you, and I'll see you in the next video. Bye bye.